dentine, correct? How do we improve the bond there? Now here, the technical things is first we etch, we bond, or if you use a self-etch technique, whichever system you're comfortable with, first we give a flowable layer for a big posterior composite because the tensile strength of the flowable composite matches closely to the dentine. So first layer is flowable and then we start doing the layering technique. Posterior composite, 1 layer, 2 layer, light cured, 3rd layer. Yeah, that's how we go. Now there have been some recent developmental changes in the biomaterials which makes it so exciting. Actually, I'm so happy to see the young crowd sitting there. This is a good time to be a dentist. It is, believe me. And there are so many new things happening. You all do your graduation, go in for a research, go in for your PG, and come over and give us something more wonderful than what we are here today. So, some conventional procedure, as I said, flowable liner, first increment, second increment, till we build up the posterior composite. And then we have the SDR. That's another step-solving thing. It makes my life easy by cutting down one step. I just give one step of SDR, and then I build the top cast for the occlusal surface with a traditional composite. Fine. If we check, the good bulk fill happens to be sonic fill from Kerr. It's a true single step, single bond, single build-up procedure with excellent results. And what does it do to me as a clinician? Oh, my working time gets drastically cut down. Yeah? Okay. So, composites, be it anterior, be it posterior, why do the bonds fail? Yeah? What can be the reasons? There are actually plenty of parameters, plenty of variables, but I have shortened down on just the very crucial ones. One is check the light you're using. The light that has been given to you, any company, doesn't matter, there's a set amount of lumes which is supposed to be produced through that light. Are you getting the same lume after 2 or 3 months of usage? Please check that. That's a very big variable. Second is, once we are bonding, dentine is supposed to be left moist. We add the primer and we have a well-formed hybrid layer. Yeah? Now, what happens? Normally, sometimes we overdry the dentine after etching. What it leaves us with is a poor hybrid layer. That's dentist's mistake. And the bond is bound to fail after a while. These are the small things. As I said, the list of variables is huge, but I'm just going to shoot through this, highlighting only the main ones. Now, bonding of composite resin. And here I am talking about a nice, big posterior restoration which we're supposed to do. It's based on collagen bonds. Dentine has more collagen, yeah, compared to the enamel. So, here my bonding is going to be based on the collagen definitely. Now, tooth's own matrix metalloproteinase enzymes, they are present inside us, in my patient's mouth, in your patient's mouth. They are there. What do? They are basically collagen destroyers, which is inherently present in the dentine. And the deterioration of bond is as much as 50% in 1 year. That's quite a bit. So what happens? The marginal leakage starts at the gingival margins. They're already there. And if you check the radiographs, decay has started degenerating. This happens with the composite. Now, this degeneration of the collagen because of the matrix metalloproteinase enzymes present inherently in the tooth is a 10-year issue still not resolved. What are we doing about it? What happens? These insoluble collagen fibrils in presence of the MMPs, they convert themselves into soluble gelatin peptides. There's a loss of continuity between the hybrid layers and the anchored mineralized collagen fibrils. Hence, this causes the loss of retention of resin composites to dentine. Very simple. And this has been there for years, for ages. Now, there's a study. I'm not going to bore you with too much of technicalities. I'm quickly going to jump to the more exciting world of clinical dentistry. But this is a study about the adhesive dentine interface which happens to be the weak link in the composite restoration. And mind you, this study has not been done in any dental school, but in the Department of Mechanical Engineering, University of Kansas. Yeah? Their finding is half of the 166 million dental restorations in the US of A in the year 2005 were replacements for failed restorations. Yeah? And the penetration of the bacterial enzymes, oral fluids, bacteria into the crevices between the tooth and the composite, are we getting a formidable bond? No. So what happens there? Undermines the restoration, leads to recurrent decay and premature failure. There goes. What is happening in the gaps? If you see the surface lesion, dentine, there's a wall lesion, composite, stained biofilm, and this gap is widening, making the tooth more vulnerable, you know, for much more decay to cause. Now, as clinical people, as clinicians, won't we love to have a restorative that is a formidable, impregnable seal to the tooth with no leakage for years and years? Obviously. I can see so many years coming up. Obviously, it's going to make everyone's life easy. Well, saliva is our friend. There's so much to saliva which we miss out normally. Quickly going through this, adding my Tufan male here, yeah, neutralizes organic acids, inhibits demineralization, enhances the remineralization, recycles the ingested fluoride, discourages bacterial growth, protein sustain enamel surface, protects the tissue, enhances taste, lubricates food, speeds oral clearance, facilitates removal of carbohydrates. These are all the good aspects of saliva. Now, coming to think of it, there was a study in 2011 stating most dental materials are designed to be passive, yeah, to have a relatively neutral existence in the mouth so that they are biocompatible, but they will cause neither harm nor injury. They'll be just sitting there. Going back to green Vardhman black, first year graduation or second year maybe, yeah, G.V. Black's process. Dental materials since G.V. Black's days were made to be passive in the oral environment, thinking this made them safe. Yeah? All opportunities to work in concert with the positive aspects of saliva. Our mouth is awash with saliva. The patient on whom we are working, their mouth is awash with saliva. So where is the usage of the saliva to creating a good restoration? Missed out. It's time to expect more from dental materials. Yeah? Now, the oral environment is exposed to constant pH cycles. We all know that. Yeah? The saliva and the tooth structure participate in that constant cycle of mineral exchange. Going briefly, how? When the pH is low, what happens? The demineralization process releases the calcium and the phosphate from the tooth surface. Then, as the pH rises, these ions interact with the fluoride ions in the saliva, precipitate onto our teeth as acid-resistant fluoropatite. Yeah? There's no rocket science. We have all gone through this in our dental books. Now, bioactive materials should participate in this ionic exchange. Bioactive materials should react to the pH cycles happening in our patients and our mouths as well. Now, GICs, RMGIs, composites have had little in common. Yeah, they have had little in common with the tooth structure, shape which we are creating with the composite, and the tooth color which the manufacturers have made to us. Hoping that there are no negative effects of the materials used. Sound cardটা একটু activate করে দেবেন স্যার? Excuse me? Sound cardটা চললো না, আপনি একটু ওই সাউন্ডটা activate করে দিন. Thank you. So, now, finally, the company which has launched this product asked the tooth, oh dear tooth, what is it that you want? To the surprise, the tooth said the tooth wanted minerals. Is the tooth tired of polymer chemistry after all? Let's check that out. So, based on this, till now, have we been giving a non-water friendly, very earthy cow as a filling material compared to the uber water-friendly dolphin as a restorative material to the tooth? Just something for all of you to think. What are we playing with as a restorative till now? So, bringing to you a revolutionary new alternative, a game-changing breakthrough in dentistry, from neutral to supernatural, from passive to bioactive, the first dental materials to combine all the benefits of composites, glass ionomers, and RNGIs, but taking care to exclude the disadvantages. Yeah? Introducing to you Bioactiva, keeping the future of restorative dentistry into our own hands, and this I'm dedicating to all that young crowd sitting there. Time for you to look into the new materials happening and give us more. Yeah? Now, the word, thanks girls and guys, the word change. Yeah, change at the onset means, oh man, already a posterior composite have to etch, bond, flowable, one layer, light cure, second layer, light cure. The steps are long. Change means this will be more tedious. Something new means some more complication. We need a long technical curve, but if I say this change is not tedious, not complicated, not technique sensitive at all, what will your reaction be? 3 cheers, yeah. So, the US FDA has allowed the following claims for Activa. It's got a bioactive resin matrix, bioactive glass fillers, and it's launched as a baseliner and the restorative. It's a true technology breakthrough. Let me quickly take you through the chemistry of this. It's exciting. I won't bore you with the technical details, no, but they are the first dental materials with a bioactive ionic resin matrix, shock-absorbing rubberized resin component, and the third part is a bioactive glass ionomer. Now this we are all familiar with, right? That's the first material which we tend to learn as soon as we join a dental school. These all mimic the physical and the chemical properties of natural teeth. Now, if we check the reactive glass fibers, they are 21.8% by weight. Silicon oxide, Al2O3, sodium fluoride, calcium fluoride, common GI chemistry. We all know what it is. I won't go into too much of details. The polyacid groups. How does it act clinically? Now, if we see in the presence of saliva, this hydrogen breaks up from the phosphate acid groups. This goes and gets attached to the calcium in the tooth, chemically bonding the resin to the tooth structure, forming a very intimate seal. What new here? Again, if we see clinically, the Activa contains Embrace, which is a bioactive ionic resin, and this chemically bonds to the tooth structure through ionization. We just saw how. But the best part is that there's no hybrid layer. So, in future, there's no chance of any gaps to form. This seal stays on and on and on for years to come. That's the best part of chemistry regarding this. Now, the third part. Rubberized urethane chemistry. Yeah? If we see, this resin matrix is UDMA. Yeah, that's UDMA, not HEMA. And by weight, the filler percentage is 57%. Now, a common question will be arising in your head that here we are talking about a posterior composite, yeah, which should be strong, which should be strength bearing, so the filler volume should be more. And here I am talking about just 55% fillers by weight. Where am I getting the strength from? I'm talking about a posterior composite here. So, the chemistry here is UDMA, the diurethane dimethacrylate. In it, hydrogenated polybutadiene rubber molecule has been added, which makes it into rubber diurethane dimethacrylate, giving it unsurpassable strength, even in clinical usage. Now here, Dentine is protective. Same, the Activa also does. Dentine is tough, Same here for Activa. Now, what happens? What is toughness? Toughness basically is the ability to absorb stress, yeah, and to resist fracture, and is measured by deflection at the break. 3-point bend test is used. The result, this patented rubberized molecule provides unparalleled toughness, and here are some figures to prove the same. Deflection at break, it is 2 to 3 times greater than composites. Graph shows. I'm not going into numbers here. And 5 to 10 times greater than GIs or RMGIs. So you can imagine what kind of strength we are talking about here. Clinically saying, I have used it in Bruxers, and excellent result. Okay. Now, how does the bioactivity happen? During the low pH, the demineralization cycle, Activa releases more phosphate. Yeah? Now, these phosphate ions reside in the pellicle layer or the saliva, and they are available to interact with calcium and phosphate ions during the high pH cycles. Ionic components are always bioavailable, facilitates the diffusion of calcium, phosphate, and fluoride ions even after curing. Now just imagine, I have maybe I have done a filling on Dr. Sadat. He goes away. But even after he has gone away, the Activa, what I filled in his cavity, still stays active for years to come. It's still continuously recharging the calcium, phosphate, fluoride in your mouth if I have done a cavity to you for years to come. So that keeps constantly being, they are all working together. Since there are 3 components, chemical reaction is 3 times. First, set by light cure. There's a dual cure chemistry and the self-cure GI reaction. It's a 2-paste auto-mix system. There are various amounts of the auto-mix tips which are available there, and you can bend it the way you want to. Upper distal part of upper 7, 8, deep left 7, you can bend it and you can do any type of cavities anytime. The short and the long ones for unique placement. It allows bulk curing at 4 mm at one go. The light cure setting time is 20 seconds. Self-cure setting time 2 minutes. That means after you have cured it, just let it be with the patient for 2 minutes and you're done. Fluoride release per day is 230 ppm. Compressive strength, not going into the names, but it is above 248, and the diametral tensile strength is again nearly 48 megapascals. So just, again, I'm trying not to go too deep into the theories. Since it's a new material, I have just tried to collate the most important things suitable for 30 minutes. Now, casually asking, what filling would you like to have? Oh, chocolate, please. Well, as a clinician, as I said, how does it make my life easy? The exciting world of health and healing of restoration. If I tell you, deep filling of 4 millimeters in first, second, or third molar you can do bang in 5 minutes. Do I get your attention now? Yeah? Well-integrated margins, they stay the same for years to come. There's no leakage, there's no loss of integrity. Bonding agent is not needed. You cut away with a very crucial part of clinical dentistry. Material behaves like dentine, looks like enamel, aesthetically very high on the rung. What else do we want? It's saliva friendly and tissue compatible. Exchanges the minerals just like tooth. We all saw that. Yes, I'm cawing like a crow, but yeah, these are all the benefits of this wonderful material which we have here today. So, the restorative dental and enamel replacement material with the strength and aesthetics of composites, but with tremendously greater toughness and fracture resistance. The conservative cavity prep restored with Activa Ionic. It's available as a gun spencer. This is the series which you attach to the spencer. Shades available are A1, A2, A3, and A3.5. Now, indications. Class 1, 2, 3, 4, 5 bits. Root surface cavities, core built up, bulk fill. Let's check out a case. It's a case of hypoplasia, missing enamel, we need to build it up. Clinical steps are so easy. Yeah, you just clean, prep the tooth to little, whatever you want to, clean, etch just for 5 to 10 seconds, not more. No bonding. One step gets cut out. Place the Activa restorative, light cure, and you are done. How much time does it take? Not more than 5 minutes. I'm telling you that, yeah? Let me take you to more clinical fields. That's a case, old amalgam case removal done by me. Remove the amalgam, okay, prep the cavity, etched, just 5-10 seconds again. Placing the Activa, this is how it's placed, there. Buccal pit, filled, and light cure, and I'm done. Now, do you think I can do only one cavity at a time? Nope. I can do at a row 3 to 4. 3 to 4 means I can tackle about 5 to 6 cavities at one time. Think how easy it can be, because all you need to do is prep the cavity, retract the cheek, your acid placing saliva control with cotton rolls, or if you're using rubber dam, and all your cavities are prepped, etch 1, 2, 3, 1, 2, 3, wash it off, keep it slightly moist, apply the Activa, light cure, light cure, light cure, light cure, light cure, light cure, you are done. So this allows multiple cavities to fill. Also, this is a case done by Dr. John Composite, who's working in close concert with Pulpdent about the researches and all, and it allows 4 mm bulk curing, very good looks, and very low shrinkage, less than 1.7%. That's the technical figure, yeah? Class 3. Yeah, I said this is a posterior composite, but can be used as an anterior also. I have been asked to work on anterior veneers, if I can use the first layer as a base and then top it up with composite, but my results are not yet out, so I won't talk about it. But class 3, just etch, fill, and there you are. And this stays healthy because the constant calcium fluoride and the phosphate ions are at play, even after you have done the filling. Multiple restorations at a time, done by Dr. Ron Kamina. Etch, again simple, fill, finish, polish, voila. Done. In kids, when the patient comes to you with a rampant caries, prep, and after one appointment, single sitting appointment with Activa, case done by Dr. Nels Olson. As a core build-up, very simple to use. Clean, etch, add, finish, polish, and you're done. Now this is a case, how many times we have seen an old crown, which is the gums have left the margins, even they must be coming to you pretty often clinically, yeah? So what do you tend to do first? Change the cap, yeah? That's the first thought which occurs. But with Activa, the decay under the crown can be happily filled up with the Activa. It chemically bonds, integrates, becomes part of the tooth. Bacterial leakage sealing is superb, and no sensitivity. That's the best part with this material. It's got no sensitivity. This is a follow-up case, Activa placed on 10/7/2012, and in 2014, after 2 years, what we can see is absolutely no leakage, nothing. It is the way you did it today, and that's how you will be finding maybe 3 years, 4 years, 5 years, because it's just launched. I don't have data more than 2 years, 3 years, but yeah, it's working. That's what. So the Activa, if I say, as it's a saliva-friendly thing, it's continuously releasing, recharging the calcium, the phosphate, and the fluoride ions, reacting to the pH changes in the mouth. Yeah. Now, again I said, I'm a very hardcore clinician.
Sorry for the interruption, excuse me. We
1
are running
minute
very
more.
much short of time.
1 minute more. That's it, I'm done. This is my last slide. Thank you, sir. I'm going to go quick with this. It's saliva friendly. And dentistry is such a beautiful field, but if I can do a case quickly and move on to some other cases, saving time, or maybe do other things which catch my passion, why not? So cutting edge, bioactive, proactive, restorative, easy handling, very simple technique, no post-op sensitivity to the patients, and saves time and money. How? Because there's no bonding agent. You're cutting that cost out. Reduces the inventory. It's a multi-use restorative. And so with that, be ready to usher a new world of dentistry, the good karma dentistry. Yeah? Only when you know better. So with that, a big thanks to the organizers, to my honorable chairpersons, the President Sir, Chaudhry Moinjan Sir, and each one of you sitting here in Dhaka. I owe my heartfelt thanks to you for giving me such a patient hearing. Thank you so much. Commercial costing. Yeah. Can you please give him a mic? Very valid question. Sir, can I? Yeah.
Dear audience, it was a very nice presentation regarding the new materials.
I can take the questions outside also, sir.
Would you like to ask any question regarding the materials? Newly introduced materials in dentistry.
First thing, its availability in Bangladesh, one. Number two, as how much it will vary the cost as the recently used composite resin.
Okay.
Compared to
right now, since with permission from Chaudhry Moinjan sir, I brought it to Bangladesh to show you what it is all about. Now we will talk about the viability of getting it to Bangladesh with his help. Now the cost factor. Cost factor, this whole package along with the gun in Indian rupees is 13,500. The gun is a one-time buy. Next time when you buy, you only buy the syringe, which comes to around 8,500 INR. Okay? Now, I can do 32 cavities, big posterior cavities with one syringe. That brings the cost to around, Sachin, can you help me? Around 300. 300 rupees to 320 per cavity. That's all. And what I'm saving is on the bonding cost. I'm not buying a bonding agent. So technically, very viable option.
Procedure of this material, you just show that after the etching, there is no need of the water wash. So if
No, there's a need of water wash, sir.
We need water
I
wash.
have to wash out the etched acid, no?
But I
No, I didn't show it because there's a huge video involving, but once I etch, I have to wash it out. And the etching remains only for 5 to 10 seconds, not more. Once I have etched that, I'm water washing it, keeping the dentine slightly moist like I would do in a composite before bonding. Only that much. That's it. It's water washed, left slightly moist, and directly comes the Activa.
Okay.
That's the process.
I'm Sadman Saqib from Dhaka Dental College. I want to know from you that you told just the advantage, I mean just the benefits of these materials.
Yeah.
But you didn't tell any